Okay. So today we're going to be talking about Chapter 5 and one of our first live lectures, so I'm excited for that. And then we will, for the lab portion, we're going to focus on the basic instruments that we've already started looking at. I'm contemplating, so our instrument book comes with PowerPoints. And so my thought was that I could do recorded lectures for the instrument PowerPoints that are pertinent to this class, and then upload them to the class, and you can use them as a resource. You don't necessarily have to listen to them, but and it might not be too exciting, but it will be filled with information that is pertinent to the instruments we're going to be studying, the instruments that we're going to be studying, the instruments that we'll be tested on, which consist of the basic instruments or the minor instruments and plastics. Okay, so I hope to get those done by the end of the week, and if not, by the weekend, and that way you guys will have that resource as well. But we're still going to talk about them in class. So anyways, just a thought on that. So we're going to be looking at instruments. And then there's a post-test. I think that's scheduled for 11:30. Let me just double check. Yeah, 11:30 for the post-test. So that's pretty much what's on the agenda for today. Chapter 5 study guide was due. And then help me remember after this, team group leaders. After we finish, if you could just stay on for a couple minutes, it shouldn't take too long. I just want to touch base with you guys, okay? Other than that, what do you guys have for me? Questions, comments? Concerns? Violent reactions?
Super nice to be back on campus yesterday for the lab.
Wasn't it?
Yeah, it was like, oh, that's right. That's what we're doing, not just these digital Zoom meetings. So that was really nice.
Thank you.
For setting
It was
that up.
nice for me too. Yeah, it's good to get to be in the same room with you guys and just be able to talk about and learn about surge tech stuff hands-on, right? It's super fun. I think it's really fun too. Awesome. Thank you, Rainey. Anybody else? Thanks, Tammy. Yeah, tell Ian, give Ian the scoop. He wants to know the scoop of how it was. Any other comments?
Trying to figure out how to get all your fingers into the right finger holes, without touching anything. That was challenging.
For open gloving, yes.
Yeah.
Yes, we learned how to put on gloves and keep them sterile. It was pretty fun. And we washed our hands, Ian, so, get ready.
And Miss Windsor taught me a great trick to keep your glasses from fogging up because you breathe too hard or something. I don't know. So that was a bonus. All these little tips and tricks.
My first tip was just to quit breathing, but she didn't like that one, so I had to go with my plan B. Yeah, the masks are so hot. I've never just grown to love wearing a mask in all the years that I've been doing this. I know, right, Ian? It totally is. I don't know. Maybe you guys will feel different than me, but wearing a mask just is never that much fun, in my opinion. But necessary and good that we have them, for sure. All right, well, I think we're going to jump into our Chapter 5 shenanigans. Chapter 5, if you want to play along, starts on page 69 in our Surge Tech book. And it's not that lengthy of a procedure. Yeah, I made her tape the mask to her face. I suggested it to Tammy too. She's like, how do you keep from fogging? I'm like, well, this is what I suggested Rainy do. But then if your skin is sweaty, or then, you know, the tape doesn't stick. So, you know, I don't know. Super glue.
Another good way is to put shaving cream on your glasses. It will keep them from fogging up.
Shaving cream. There you go. All of those of you that got face shields, buy some shaving cream. In the operating room, they have, and we use it in endoscopies or laparoscopies, I guess. It's called Anti-Fog, or Fred is like a brand name of it. And it's like a little tiny bottle with some magic stuff in it. And, you know, once we use it to keep the scope from fogging, well, it has like a little foamy pad that you like put the liquid on, and then you can stick, it has a sticky back, you stick it to your field, and then you can wipe the end of the scope on it before you put it into the belly, and, or whatever, usually the belly. And so what we'll do as surge techs, you'll see this, is like wet the pad and then like pre-operatively while you're still clean, and then put the cap on and toss it off the field so that later you can get it and put it in your pocket and keep it for like putting on your glasses. It's really handy, and you typically don't have to re-wet the sponge once you wet it once. So, and you might see little bottles of it, like they're only about this big, like sitting on the scrub sink, you know, because people will save them and like put them up there, and you can use them for your glasses. So kind of the same thing. Thanks for that tip, Jonathan. Okay, we are going to go to the PowerPoint. I will post this as well. The one that is in there is not my spruced up one. So maybe it wants to share. Okay. Can you guys see this? Okay, thanks. Let me get the chat open here. Okay. Trying to get everything arranged. Present. Ta-da! All right. You know me, I always like to have some funny cartoon. I don't know why this isn't really even similar, but when I read this cartoon, it made me think of when the Diamondbacks were in the World Series. I don't know if you guys remember that. No yawning, Jonathan. It's way too early for that. Okay. And so we were in surgery and the Diamondbacks were playing, and we kept telling our nurse, Mary Ann, to like go out into the lounge and check to see what the score was. So, you know, this can be real. We can send nurses to do strange things for us. But yeah, and truthfully, when surgeons don't do a particular procedure often, then they do have to kind of revisit what the technique is, right? So anyways, having said that, let me see if I can figure out how to advance the slide. Okay, so chapter 5 focuses on the surgical patient, and it talks about something called patient-centered care. And so my question for you is, have any of you ever been a surgical patient? A surgical one? Jonathan raised his hand. I can't see everyone. If you like want to put it in the chat, like a Y or an N, that would be fantastic. So we can see how many of us. I'm going to put mine in. There's me. Yes, times 13. Okay, let me see how many yeses we have. 1, 2, 3, 4, 5, 6. I'm with you, Rainey. 7, 8, 9, 10. All right, maybe about half of us, not quite half of us. So those of you that have been surgical patients, tell me a little bit about what you were feeling. Anybody want to start that discussion off, kick it off?
Well, I had a torn ACL, and more or less I was excited the day that it finally came because I wasn't going to be walking around with a limp. But then, like, as the time came, yeah, extremely nervous. I was like starting to freak out once they started shaving my leg because they had to do that.
Yes, it is very nerve-wracking, and I'm not sure, but I suspect that the more you know about surgery, the more nervous you actually are. Like the not knowing, I don't know, for me, like the more I learned about surgery, like when I had my hip replaced, I've been doing this for 10 years almost. I think I felt more scared knowing what they were going to do to me than not knowing all of the details.
I was also fresh from watching like in anatomy and physiology back then, and we watched a bunch of ACL surgeries and hip replacement surgeries. So yeah, I was fresh off that, so I was a little more nervous then.
Yeah, I think it definitely did that for me too. What is Ian saying? Oh, your dad, Ian's saying his dad had the same surgery, so he kind of knew what to expect. You know, you bring up a good point because in the operating room, we really don't have much contact with the patient before to know what they've been through to get there, right? We all know as patients that there are a myriad of tests that have to be ran before you can actually, go through those double doors into the OR. And so we don't really see that. And we don't really see the post-op, right? So for me, with my total hip replacement, I had no idea what was coming. I mean, I knew what happened in surgery, but I really didn't have a good understanding of what the post-op recovery was going to entail. And I'm glad that I didn't know because I probably would have made a different decision because it was not the funnest thing that I've ever been through. Yeah, Sarah is saying she was cold. It's freezing in there, right? It's freezing, it's scary. There's all of these people that you don't know, you can't see their faces. They're kind of all flocking around you at the same time. That's really intimidating. Our fingers are important, Ian. Don't downplay that. Alyssa had a tonsillectomy at 17. Yeah, and they say that it's worse as an adult, right? That it's more painful, it's more recovery, it's more risky. Yeah. You are completely vulnerable. You're absolutely right. So scary. Putting your trust in complete strangers. Yeah, the anesthesia makes you feel really weird, right? I always get a kick out of my mom after anesthesia because she loves everyone. She's like, I love you. Thank you so much. Like to all the nurses, everyone who cares for her. For me, I get really sick after anesthesia. And so that is always something that I worry about.
Yeah, I came up with some patented ideas under anesthesia. There was a big blue ice on my thing. I told them that I had to keep it and they couldn't take it away, but it was mine anyways. And then on the way out, I kept trying to lean my head back, but there was no headrest because I was in a wheelchair. And I was like, I'm going to create a headrest for these wheelchairs because this is ridiculous. And the nurse was like, wow, that might be a great idea. And I was like, that's copyrighted. I made that up. And
That's a totally great idea. You should write that down, put it in an envelope, and email it to yourself. Don't open the envelope. So if everybody ever does it, you can take them to court and say, look, this is postmarked on this date. this was my idea. Apparently
Patented.
that will hold up in court. I don't know if that's true or not, but let me see what some of the other comments were. Tori saying she doesn't remember anything. So that's an interesting thing that you bring up too, because the medications that anesthesia gives us, like the Versed, which is kind of like the little cocktail to help us not be so nervous, it has a what's called a retroamnesia effect. So at the onset of it, it is going to make you not remember things that happened like prior to them giving it to you, which is very strange.
Yeah, when I had my wisdom teeth pulled and then I had an endoscopy, I don't remember anything, like at least an hour before, maybe even two. Like I remember walking into the buildings and that's it. Like I don't remember anything else. And then my mom would, one time she said, "Oh, we went out to eat afterwards after we picked you up." And she's like, "And you ate and you said it was delicious." And I was like, "I don't remember anything. I don't remember anything." Like I hope it was good, but yeah, no.
Are you really sensitive to medications?
Yeah, I am.
Yeah. Yeah. So I think the more sensitive we are, the more dramatic like that retroamnesia effect is. And when I worked at the surgery center, we had, I don't know, I guess you can call them frequent flyers, but they would have a procedure done there and then they would think of us again when they needed another procedure. And so we might have, patients come in a couple times, like they have one eye done and then they come back and have another eye or whatever. And they always say, as they're rolling in, "I had surgery before, but I don't remember any of this." And we're like, "Yeah, you're not going to remember any of it this time either." But, so that's kind of a common thing that we hear. Let's see, what else? The countdown. Yeah, that's a typical thing. I guess, I remember when I had my hip replaced, um, the the anesthesiologist said, "I'm going to put some stickers on your chest, like the EKG leads stickers." And I just remember the last thing I remember, because I do remember going into the operating room and scooting over onto the bed. And then he said, "I'm going to put some stickers on you." And I just remember saying how much I loved stickers. And I was so happy that he was giving me some stickers. So anyways, that's my brain on drugs. No problem, Robbie. We're just talking about if we've had surgery before and kind of what our feelings were about that. Right. So Jackie, that's a really good thing you bring up, and we'll talk about that a little bit more in the chapter about, what the book indicates as patient fears, but that's a big one, the fear of not waking up. And when I worked at the hospital, they started a Saturday shift that was like where you could schedule elective cases. And so I was working 3/12s at the time, Tuesday, Thursday, and then this weird Saturday thing, 7A to 7P. And doctors could schedule elective cases on Saturday. And so we had a patient that was scheduled to get her tubes tied. And I remember being in the operating room. My nurse and I opened everything. I scrubbed in. She tied me up. She said, "Okay, I'm going to go check on the patient." So I was just doing my thing. She comes back and she says, "I'm pretty sure we're going to cancel this case." And I'm like, "Oh, like, did the patient eat? Does the patient have a fever? Like, what's the deal?" She said, "Well, the patient shared with me when I interviewed her that she is afraid she's not going to wake up." So she communicated that to the anesthesia care provider, and anesthesia canceled the case because the power of the mind is a very strong thing. And she was pretty, I guess, I mean, I don't know, I never talked to her, but they interpreted it as, she felt like she was going to die during surgery. And so since it was elective, we canceled it. So it's a real thing. Yeah, anesthesia. They say that there's a higher chance of dying from the anesthesia during surgery than from the actual surgery that we're doing. So, oh, Sarah, that's so scary. What was going on? Why did you have to have surgery? Can you share? Or if not, that's okay.
Yeah, I was in a lot of pain, so I went into the hospital and they thought I was having a ectopic pregnancy. But they found a tumor on my left ovary. So I had to go in. The x-ray showed that it was on the right side, but the pain was on the left side. So they did an exploratory and it was on the left, and the tumor was so big it took over my ovary and fallopian tube. So they had to remove it all.
Oh, geez, that's so scary. I can't imagine. I mean, I know there's been just only a couple times in my career that we had a pregnant woman that we operated on for, I don't know, typically it's right after they give birth. Like a lot of mamas will need their gallbladders out, but that's something that's kind of common, while they're pregnant, appendectomy or a gallbladder. So yeah.
The reason they had to do mine right away is because they couldn't get the pain under control. So they had me on Dilaudid. Every hour I was getting another
Dose.
yeah.
Yeah.
So that's why they had to take it out right then.
Wow. Well, I'm glad you're okay. That's really scary. Yeah. Thank you for sharing. Let's see, Hannah. What are you saying? Oh, you had ankle surgery? You were hitting on your ortho doc? Yeah. I've actually been witness to that. It's actually super cute. Ariana. So Ariana is asking, does the cocktail have the same psychoactive drug-like effect on the brain? Like what specifically? Can you speak more to that so I can understand?
I think my question kind of pertains to the fact that I've seen a lot of videos of like people just waking up and acting really like they're on drugs. So I'm curious how that feels, and I'm curious like is it similar to like being on something and like being, I don't know, because it looks like people are like high pretty much.
I think that it's a very similar feeling. For me, I hate that feeling, like that loss of control or not being in control, because for me, like when I'm waking up, I can't help but like fight against wanting to, like, because you're still super sleepy, which is the worst feeling. But, and I think different people react differently depending, but I think it's very similar. Yeah. Tammy's saying that after anesthesia, she has anxiety. Yeah, that's it. It's awful. I feel like that too. My one other thought about the cocktail question, there is a drug called ketamine, and ketamine's actually a hallucinogen, and they used to use it a lot for anesthesia, but now predominantly they use it minimally for when they're going to operate on your brain, poke around in your brain, and they want you to stay awake for it so that you can respond. Like sometimes they'll be removing tumors from like Broca's area, or, the area where it's responsible for speech or motor, or something like that. And as they're working, they're like, somebody else is talking to the patient, like showing them images and having them respond, or whatever the case may be. And so ketamine is what they give, but it does have a high tendency to give hallucinations like after you've been given it. So yeah, they use it infrequently. Special K. Yep, you were right, Ian. Very good. Very good. Good discussion. Yeah, it's really scary. And so having said that, this patient-centered care approach that the book talks about, is really is a holistic approach to taking care of the patient, right? Everybody's on the same page. The patient has a say. The family is involved. It's like this whole, team approach. And so I have a little video. It's not too long on patient-centered care. Can you guys see this video? Can somebody tell me yay or nay? No? Okay. Darn. All right, hold on one sec. Figure out how to get back to you. My computer's being weird. Okay, stop sharing. Okay, let me switch to the video. I was hoping it would just like jump over, but I guess not. Okay. How about now? Okay. Thank you. All right, here we go.
Things have changed over the years I've been coming here. I've got a lot more trust in the doctors because of the way they treat me now than I did years ago. Dr. Eagle, he came in today. He talked to me like it's unbelievable the way he talked to me. It was great. And he's telling me what's going to happen, and he made me feel better about everything. I've got something very serious wrong, but these doctors, they're going to take care of me.
So the whole notion of patient and family-centered care, I think, is the notion that we're in the care journey together. It's not we are caring for you. It's we, including you, are working together on trying to improve your health state. So what does that mean? First is they're the center of the whole team. Now, they're on the team. The team starts with them. They have to fully embrace their participation. We have to find transparency with how we communicate and document their medical journey. They have to have access to that.
As soon as I show up at the bedside, the patient already has a story in their mind that they're ready to share. They already have questions, they've got fears.
When we include them and we explain to them why we're getting the tests that we're getting and what these tests are showing and how they're guiding our management, I think it empowers them, makes them feel like they're a part of their care, and I think it makes their entire day and their entire hospitalization run a lot more smooth.
I do believe that they do give a lot of consideration to questions and my concerns as well as my family's.
When you have family around, if I don't think of things, then she does. And then she brings it up. Because I think you have to have somebody out there to speak for you.
It seems to catch potential drop balls or errors. And I think it certainly increases the confidence that the patient and family has that there's a continuum of both care and communication around the care that is not missing things, and that is open to criticism or critique if somebody says, well, mom's not on that drug. That happens. It's a complex world.
The families feel more comfortable, the patient feels more comfortable. They are given choices now, and who's going to take care of the patient when they get home? But the family.
My preference is to go into the room, sit on the bed with the patient, introduce all of the members of the care team, what they do, and then say to the patient and the family, we're going to talk about your care now, and somebody's going to lead it, and I'm going to comment. And then at the end, we want to make sure that we are all on the same page with what your care plan is, that any questions or fears that you have been answered, and anything else that we can do to make your stay comfortable. When we do rounds, if the nurse isn't there with the care team, then the likelihood that communication will be seamless between what the physician side may want and what the nurses will implement through the orders may break down.
I loved around with the doctors.
The nurses treating you all right, or they rough?
No, actually. His nursing care is excellent. A lot of times rounds can be very intimidating, and sometimes the patients forget to ask questions. So sometimes I might chime in and say, hey, didn't you want to ask about that procedure? I try to keep my patient as informed as possible.
You may have seen we have a whiteboard that has a list of who the doctors are, who the nurse is, who the students are. And it has a kind of the daily care plan, what's going to happen today, and what are the goals for today. That's very helpful because sometimes we forget things, you know, rounds are going by and suddenly at 2 o'clock, the patient's trying to remember what's happening to my care today is there. The other thing that's happening is the whole way the nursing shift change is occurring has evolved. The nurse who's been on the day shift is sitting with the patient and family with the new nurse who's taking over. And so there's this transparency. I was your nurse earlier today. This woman or man is going to be your nurse for the next 8 hours. And I'm going to discuss with them what we did today and what the plan is so that we're all on the same page.
Coming to U of M, I was a little skeptical because of it being a teaching hospital, that you have a doctor come in with an entourage, but I feel like everyone communicates. They communicate with my doctor and they communicated with the doctor that did my procedure, and I just feel like anything that came about from my visit with Dr. Eagle today is going to be communicated to the other physicians.
Nowadays, medicine's really a team sport. And so there's not only attending, but the house officers like myself, but also the medical students and the pharmacy students. And so, you know, we're all involved in the patient's care. So I think it's important that the patient, you know, is introduced to all of these people that are taking care of them.
If they're here on it as a team and they feel that I'm not satisfied with what they told me, okay, what do you want repeated? What don't you understand?
The patient would prefer to be communicated to instead of just, you know, having the care team communicate behind their back and then having this incomplete information in front of them. We're making life or death decisions, and those kind of decisions, they require more than 2 to 3 minutes in the room.
There may be some insight that family has that I don't have on things that work for that patient, and if we can incorporate the physicians, the goals will become the same for everybody and we have better patient outcomes.
Patient satisfaction scores have been a motivator for many people to incorporate these types of practices and principles. Additionally, literature is showing more and more our patients and families, when they are part of the care planning, we actually have better outcomes. We have reduced length of stays, we have reduced readmissions, we have less errors, and when you do all of these things, you are obviously affecting clinical outcome.
One of my very favorite quotes ever is Maya Angelou's. She said, "In my life, I've come to realize that people will forget what you said, and people will forget what you did, but they'll never forget how you made them feel." And that's where we have the opportunity to actually help all of our patients and our families heal in ways that may be beyond the actual healing outcome, but heal as human beings, right? It's putting the humanity back in healthcare.
Yes, I love that. Isn't it true though? Like, you never forget how people make you feel, right? I mean, you may not remember what they said and you may not remember what they did, but how that feeling when you recall that is what really sticks, right? What do you guys think of that video? Pretty good.
It's funny too, because as a healthcare worker, going in and like interacting with patients who've interacted with other healthcare workers they didn't like, you get to hear all about it.
Yes, definitely. They are willing, right? It's like that in business and marketing, we talk about word of mouth, right? If one person has a good experience, they might tell one person. If they have a bad experience, they're going to tell at least 10 people, right? And it's the same thing here, right? Because this is patient care is customer service, right? And you know, Rainey was asking a really great question about how COVID is impacting patient care just from the aspect of like you're disconnected from your family, right? So for me, like my first thought is we have to be more diligent about communicating. Like we still need to have that communication with the family, whether it's before or after or during, where we're making that effort to, you know, maybe the communication is different. Maybe it's via phone, maybe, you know, those kinds of things, but still finding some way to communicate. But it's definitely made it more difficult, you know. Sean, what do you think?
I'm sorry, who?
I was just wondering, since you're kind of out there, like what your thoughts are, those of you that are kind of on the front lines.
I would agree. I mean, I would definitely agree on that, for sure.
Yeah, it's definitely changing the way we communicate and making it a little bit more where we have to put even more effort into it and be more cognizant, right? So a couple questions for you. Like, I really like that video because at the end of the day, it's about patient outcomes, right? And they talked about that a couple times near the end. But we've talked about being a surgical patient and how that makes us feel. We've all been a patient at some point. Yes, so the patient, Tammy, is an integral part of the team, right? Super important that they, you know, they're in the starring role, right, of their care. And we've had quite a good discussion about how surgery makes us feel scared, cold, anxious, weird, out of sorts, vulnerable, all of that stuff. And sorry, Mrs. Brombeck is calling me. Let me just tell her that I'm in class. She should know this. Maybe it's an emergency. So what are some of the things, so we've all been patients before, right? If we went to a doctor's office, we've all been to a doctor's office before and been a patient in that aspect. So tell me some of the things that make you feel better. What were some things that made you feel better or less anxious or less vulnerable? A warm blanket, absolutely, right? And as surge techs, if we're not scrubbed in, we can be a part of that too, right? You see the patient come in and you're just maybe in there helping, you know, tie up a fellow surge tech's gown or whatever the case may be. Go grab a couple warm blankets, right? If one is good, two is better, kind of thing. Yes, personal contact. Oh my gosh, that kind of gives me goosebumps, Rainey, that you brought that up, because one of the older nurses that I worked with, a gentleman named Ron, he would always, when the anesthesia care provider was putting the patient to sleep, I just have this picture of him in my mind, how he's, if you think of how the patient's on the bed and the arm boards are out this way, he would stand kind of near the axilla area of the patient, one hand in the patient's hand and the other hand like across the patient, like on their leg or their hip or their side. And he just literally just stood there with his hands placed on the patient, holding their hand, just, you know, saying some calm words like, you're going to go off to sleep now and everything's going to be okay. You know, and that is so important. Grab a hand or you know, just a reassuring word of some kind. Yeah, absolutely. Eye contact is so important, right? Yes, I agree with you 100%. Other thoughts? What made you feel better? Trying to think what made me feel better. I don't know. It's so scary. But I think one thing that makes me feel better is you know, when you get that sense that your healthcare provider, whether it's a nurse or a doctor or whoever, is like in a rush or has an attitude, like you kind of get the feeling like they're overwhelmed and they're exasperated and you're just one other patient on their list of, you know, of boxes to check, that doesn't make me feel good. So when somebody like sits down and takes the time, I remember something that really left an impression on me was when my mom had her knee replaced. She had it done at Thompson Peak. And so I can remember being in pre-op and my mom gets really super nervous and she has hypertension anyways, and they won't give her anything until right before surgery, and her blood pressure just has this tendency to keep going up and up and up and up. And so she was getting a little bit nervous, and the nurse came in, the pre-op nurse, just to kind of check on her and saw that her pressure was up a little bit. She literally, like, it was right before Christmas, excuse me. And so the pre-op nurse pulled up a chair, because my dad and I, my stepdad and I were there, and sat down and started talking to my mom. It literally felt like family. Like she was showing us pictures of her Christmas trees, and we were just talking and laughing. And so then I shared a picture of my Christmas tree, and it just felt like family. That's the only way that I can think of it. She just made my mom feel so much better and relaxed and at ease, just kind of taking her mind off things. And she took a minute to do that. And I know they have other patients, but I think that's one thing that helps me to feel better. A genuine answer. Yeah. A canned soup is never nice, right? Like just kind of brushing you off. Or another thing I wrote down that I thought while I was watching the video, is just using plain language, right? Like, can you remember before you knew medical terminology and healthcare provider came in to talk to you and they use all of these big words, or maybe you go with a family member that isn't so familiar with the verbiage and they're using all of these big long medical terms, and you're scared anyways, right? As a patient, maybe you're waiting to get some test results or what, and you have all this noise in your mind about that, and all of these big long words are coming out. So, I think when we talk to patients and surg techs, we have very few conversations with patients where they actually remember it the next day. But when we do, I think it's important to just use plain language, Humor, yes. Yep, I think humor is good as well. There's definitely a place for it. I agree, Rainey. One of the things that they mentioned was communication. And I know this has been a common thread for us, but one of the things that came to my mind was an experience that happened to me when I was working at a surgery center in Tucson. And it's one thing that, we're kind of faced with on a regular basis is special implants for whatever surgery we're doing. Maybe we're fixing a fracture, maybe it's a plastic surgery, whatever it is. If there's some sort of implant that is going to be put into the patient, we need to do our due diligence before that surgery and make sure we have the right stuff. So I was in a situation that felt very horrible, where we had a patient that was in for a breast augmentation, and she had planned on getting silicone implants. And so there was two ways that we got the implants for those procedures. If it was a self-pay and the patient was paying and it wasn't going through insurance, the doctor's office ordered the implants. If it had something to do with medical insurance, our facility was faxed to our purchasing manager. The office would fax the order, and our facility, our purchasing manager, would order the implants and have them there. So on this particular time was a situation where our facility was supposed to order the implants. So here we are in surgery. We have prepared the first breast for the implant. Okay, we have dissected all of the tissue off from the muscle, the pectoralis muscle, and we're ready for the implant. And they're stacked up in the room, right? Like when I was getting ready for my case, I glanced over and I was like, okay, there's the implants. So we had them, but I didn't go look at them. I didn't ask the surgeon or the nurse, like, do we have the right ones? Somebody check them that knows more than me about what this patient is getting. I didn't do that. I did look to see if they were there. So intraoperatively, the surgeon says, okay, I'm going to take this size. And so the nurse goes over and she gets that size and she shows it to him. And he's like, what is this? And she's like, what do you mean? You asked for this size. He's like, no, these are saline implants. Where are the silicone ones? And she's like, so she goes back over to the stack and she looks and she's like, these are all saline implants. And he said, the request was for silicone implants. This is what the patient wants. So anyways, of course, he was mad at the purchasing manager, but he was also mad at himself because he didn't check the implants beforehand either. So he had to go out. We just stood there in the operating room waiting for him while he went out and talked to the patient's husband to say, okay, this is the situation. Do you want us to put, what would she want? I mean, how would you like to make this decision for your spouse or your child or your mom, whoever? Should we, we're in the middle of surgery. Should we sew her up and wake her up and tell her she didn't get her surgery? Should we put in the saline implants, the ones that she specifically said she did not want? That was our situation. There aren't any peeps out there that have these implants on hand. So that was the only two choices. And the husband said she would want the implants. So we put in saline implants. Subsequently, she did not have to pay for her surgery, and the surgery center ate the whole thing. So I cannot reiterate how important it is for checks and balances because all of us that are providing care are only human. We're only human and we're fallible because we're humans. And that's why there are so many instances in surgery where there are checks and balances, like counting, right? I'm counting and my nurse is watching. It has nothing other to do with it, other than the fact that we're human, we're fallible, and 2 heads, 4 eyeballs are better than 1 head, 2 eyeballs, right? So that was one thing that came to mind and one situation that still hurts my heart. I'm not gonna lie. I think we've pretty much covered patient-centered care. Questions, additional comments about this information? Thoughts? Okay, so I'm going to stop sharing. We're going to take a break because we've been at this for about 50 minutes. So let's take a 10-minute break and we'll come back and we will look at Maslow's hierarchy of needs. Okay, so I'll see you at 9 o'clock straight up. Sound good? Okay.
Can you hear me, Miss Windsor?
Yes, ma'am.
Cool. Just wanted to double check.
Mic check.
Thank you so much.
Yep, you got it. Okay. So like I was saying, there's this guy, his name is Maslow, and he came up with this idea a long time ago called the Maslow's hierarchy of needs. And so I have a little video for us to watch about Maslow's hierarchy of needs. It just kind of gives a very basic, like 2-minute little spiel about this pyramid here that we're looking at. And then we'll talk about it a little bit more in detail. I guess I have to stop and then restart again. Hold on 1 second. This is a little bit persnickety. Starting without us.
How do we become happy? A question that has been asked since the dawn of man and answered
I need to make it bigger. Okay, here we go.
by philosophers, gurus, and recently psychologists. One of them was Abraham Maslow, who formulated his hierarchy of needs, also known as Maslow's pyramid. What can we learn from this pyramid if we want to be happy? Maslow's pyramid is divided in 5 levels: physiological, safety, love and belonging, esteem, and self-actualization needs. Physiological needs are biological and physical requirements, like breathing, food, water, and sleep. When these needs are not fulfilled, they become the only thing we are preoccupied with. Safety needs are physical safety and needs for home, employment, income, and health. Without fulfillment of these needs, a person feels constantly insecure and unprotected. Love and belonging needs deal with our desires for good family relationships, friendships, and sexual intimacy. Without them, we might become depressed or experience loneliness. Esteem needs are needs like self-esteem, confidence, achievement, and respect by others. Self-actualization needs deal with creativity, spontaneity, and problem solving. Self-actualizing people have a grounded sense of well-being and satisfaction, and a sense of awe, wonder, and gratitude about life. Maslow noted that his hierarchy is a general description. Levels are not fixed, and each need does not have to be fulfilled 100% to move to higher levels. So, how do we become happy? Maslow called the lower 4 levels deficiency needs. If we don't have them met, it influences our psychological health and obstructs our tendency for growth, autonomy, identity, and excellence. Fulfill your needs at all levels to make truly a happy person.
Okay, there it is in a nutshell. Now we all know how to become happy. Now we can go out and do it, right?
As simple as that.
It's as simple as that. What do you guys think? Okay, I'm going to switch back to the PowerPoint while you guys are thinking. Any immediate comments about the video or Maslow's hierarchy? Have you guys heard about Maslow's hierarchy before, or is this the first time? Okay, Jackie, first time. All right, awesome.
I've heard about it when I was taking my psychology course and counseling courses.
Yep, definitely is going to come up in there.
Mm-hmm.
Yes. Anybody else? Couple people first time, couple people have heard of it before. One of the things that it says in the video is that one level doesn't need to be met before you can proceed to the next level. But the little caveat is it doesn't need to be fulfilled 100%. So I kind of disagree with that a little bit, because if our physiological needs are not met, like what are some examples of physiological needs? What did it say? Or what does the book say?
Like food.
Food, right? Mm-hmm. If you can't get food, are you going to be worried about getting a college education? Probably not. What about air? If you can't breathe, are you going to be worried about the other levels? So at some point, the majority of those needs need to be met. Now, I might have physiological needs like food, and I have food to eat. It might be beans and potatoes, or top ramen. It might not be steak and shrimps like I really want to eat, right? But for the most part, we need food to eat, we need water to drink, we need air to breathe, right? Comments? Okay, so let me go to the next slide. So we're going to talk about each of these a little bit more in detail. So here's a question for you all. Which level of Maslow's hierarchy is the main focus of the surgical team?
Security and safety.
Security and safety. See physiological and safety. Psychological. Okay, did you mean physiological, Jacob? Yep. Yeah, I would say for the most part, we're focused on the physical, most basic level, foundational level of Maslow's hierarchy of needs. I definitely think safety falls in there as well. But when we're looking at the physiological needs, we're looking at breathing, right? We're looking at nutrition, transport, excretion, right? Reproduction, repair, movements, those kinds of things. And all of those play a huge role in what we're doing as far as patient care. It mentions reproduction. Yes, reproduction of other humans can play into it, but cellular reproduction is an important part too. That's why we talk about minimal handling of tissue. Like the more we handle tissue, the more we pull on it, burn it, retract it, whatever the case may be, the more we manipulate it, the higher the risk is that we can damage it either permanently or at least make it mad enough that it's going to slow down the healing process, right? So tissue handling comes into play when we talk about cellular reproduction. Positioning of the patient is a big one. Once we put the patient to sleep, they can't say, ow, don't turn my neck that way, it hurts. Or don't turn my neck that way and leave it that way for 6 hours because it is gonna hurt, right? Because when we're sleeping in our bed at night, and I don't know if you guys are the same, like I'm a side sleeper, but I'll sleep on that side for a while, but I don't typically go to sleep in the same position that I wake up in. Or sometimes I'll wake up a little bit to roll over on the other side, right? Because my hip needs a break or my shoulder needs a break on that side, right? So, when we're sleeping in bed at night, we can rouse ourselves and reposition ourselves so we're a little bit more comfy, but the surgical patient can't do that. So being really cognizant about positioning them and how we move them, and then their range of motion, right? When they're awake, they may only be able to stretch out their arm to a 45-degree angle at the elbow, but when they're under general anesthesia, they can stretch it all the way out. So those are some things that we need to be, aware of when it comes to patient positioning. Now, if we are scrubbed in on a case, we're not going to be involved in that. But we can take a peek-see at the patient and offer some suggestions if, we're doing a shoulder scope and they put the patient's head in a positioning device and the neck is like to the side. You can say, oh, well, we kind of maybe need to bring the head a little bit more to the right because it's a little bit wonky or whatever. So we can definitely just be an extra pair of eyes, right? Like we've talked about, extra pair of eyes and ears. And then excretion, right? If we're gonna have the patient asleep for several hours, they're gonna need to void, right? So then that's where we need to think about as far as a holistic approach to healthcare. We can still make those suggestions too. Like, you're gonna be doing a certain case, like, is this patient gonna need a catheter or whatever the case? I can bring that in, so those are things to think about as well. So let me click here. So physiological, all right? And so here's some examples, pretty much as similar as the book talks about. Questions or comments about the physiological needs? Anything? Let me see your question, Tammy. That's a great question. The first thing that comes to mind isn't exactly in response to the question you're asking, but I'll share it with you. I had a situation where we had a new to the OR nurse. Her name was Shady. And Shady had been a telemetry nurse, and she had worked in the cardiac cath lab, but she was not an OR nurse. And so she wanted to cross-train, and they had been cross-training her. And now I was in the room with her by myself. Well, she and I and, the peeps, but she wasn't being precepted. And so we were doing a urology case where the patient's legs needed to be put up in stirrups. And we use these little things called Allen stirrups, and they hook to the bed, and then they're like these little boots. You guys will see them. And their feet fit in there, and it supports like their calf, right? So basically we're putting them in a lithotomy position. So I was setting up my field, and the patient kind of comes in while her back is turned, and now the patient is asleep, and I'm done with my setup because it's relatively minimal. And I'm just kind of standing to the side of my table, just like facing the room, just standing there. And so I'm just, I don't know, my eyes are warm, just looking around. I'm bored, I'm just waiting. And I notice that the stirrups, those Allen stirrups, have been attached to the bottom section of the bed, and not the section where the torso is, but the section that we drop down, all the way down when we do said case. And so I got her attention, and she came over, and I said, the stirrups aren't attached to the correct section of the bed. So when if this were to have happened and they put the legs down and somebody wasn't paying attention, it could have pulled the patient completely off the table. And she looked at me and she said, "Are you trying to say I did something wrong?" I'm like, "No, it's just, confusing, and you're new, and it just needs to go on that center section." And she's like, "Well, if it's wrong, the doctor can tell me that it's wrong." And I said, "Okay." So the surgeon finally came in, and the first thing he does is he comes in and he looks at the positioning, and he says, guess what he says? "The stirrups are not attached to the correct section of the bed. They need to be attached to this section." So I have had that situation where, and it's not been the only situation where I've suggested to the circulating nurse, "Hey, did you check to see if it was plugged in? Because a piece of equipment isn't working." And you get the skunk eye, right? They're like, "You think I'm really stupid enough to tell you it's not working if it's not plugged in?" And then they go and check, and it's maybe backed out of the socket a little bit, or a lot of times the cord plugs into the back of the machine and not just the wall. So I have had situations like that. Sadly. Not a whole lot, but a couple. I also had situations where I was getting ready to leave for the day at the surgery center. My room was ready, and I was just going around to the other rooms to see if anybody needed help. Exactly, Ariana, and this is another sad example of that. One of the nurses was in her room, what would be her room the next day, setting up for a shoulder scope, I think. And so she was the only one. Everybody else had pretty much gone, and she was still in there setting up her room. And so I was just going to offer to help her before I left. And so I stopped in and I said, "Hey, is there anything I can do to help you? And she stopped and she looked at me and she said, if you can't look around and see what needs to be done, then obviously you can't help me. And I said, okay, have a good day. I'll see you tomorrow. And out the door I went. And really did not feel inclined to ever ask her again if she needed help. Not that I didn't ever help her again, but my feeling was just, I had a snarky feeling. I'm not going to lie. There's no reason why we have to treat each other like that. I never really quite understood that. But, I'm not a stranger to orthopedics. It's not like I was the eye tech asking, only doing eyeballs my whole life, asking her if she needed help because she and I had worked together a lot. So there are going to be those situations where you just have to either just let it roll off like water off a duck's back, or if you have a situation where something does look wonky with positioning, you just need to be assertive. And that's easier for some of us than it is others. It's not easy for me to be assertive. That's not the way that I'm wired. I've kind of had to, I had to get some on-the-job training for that, let's just say. Other questions or comments? Security. So security, according to the book, is the absence of perceived or real physical or psychological harm. And I definitely agree with those of you that said security is also something we need to provide. It's really scary being a patient. And, we've talked about some of the fears already just from a personal standpoint. The book mentions anesthesia, which we've already talked about, death, which we spoke about, loss of control, which we spoke about, loss of privacy, because we said we feel vulnerable, right? I can remember when I had my hip replaced, I knew the ortho device rep that was going to be in the room. And I know that they strip you down to your nothings and put you in this really precarious position. And knowing that this individual might be in there caused me a bit of anxiety. So if you work at a facility and you're having surgery there, that's even more daunting. And there have been situations in my past work life where a patient requests an all-female team or a patient requests an all-male team. I also had a situation where my boss came to me. This was in my hometown somewhat hometown, quasi-hometown of Casa Grande. My boss came to me and said, I'm not going to put you in XYZ case tomorrow because the patient has requested that you not be in there. I'm like, what? What did I do? I come to find out it was a friend of the family, kind of friend of the family, that just didn't feel comfortable, having me in there. So, so patients can definitely request that. Yes. Especially, you think about if you're having some sort of rectal procedure or vaginal procedure or, whatever the case may be, wherever we're working is largely exposed. And that's just daunting in and of itself, right? And so a lot of times, all times, whenever we can, we're going to wait till the patient is asleep to bring out the weird positioning devices. Even with suction DNCs, when we have a patient that comes in with a miscarriage or a missed abortion, we will hide that equipment out of sight. Whatever we can do, it's weird enough in that environment to not to reduce the anxiety with that. Let me look at Rainey's comment. Right? Absolutely. That's an uncomfortable situation for sure. Absolutely. Yeah, I actually, one of the surgeons I worked with in Tucson at the surgery center, he was my GYN. And it was kind of weird when we did cases together. I'm not going to lie. I would be like, "Ugh." But, you know, he was totally professional, totally sweet. But, you know, my grandmother was born and raised in a really small town here in the southeast part of the state. And I can remember her telling me she was going for a colonoscopy and how embarrassed she felt. But the one thing that helped her not feel so weird was that she wouldn't know anybody. And she said afterwards that she was waiting in the pre-op holding area, and this young guy walks in and says, oh, do you remember me? Like, I went to school with your son. And she was like, great. Like, this was the only thing that I could, you know, use to psych myself out to get this done, and now that's gone. So, yeah. Let's see what else. A couple other things that the book mentions. Pain, right? Pain is definitely one. Disfigurement, so body image, loss of control, physical exposure, loss of privacy. So things that we can do, make sure all of their questions are answered. And if we can't answer them, connect them with someone who can. So the more, you know, communication, the more communicative we are, the better. As far as pain, pre-op education is going to be a good thing. And make sure they understand how to take their medications. And, you know, a lot of people will not take pain medication unless their pain gets really so super bad that they can't stand it, which is the wrong way to take pain meds, right? Because pain is easier to keep up with than to treat once it's like at a 10. So, you know, just that patient education is a big part. Empathy, I think, is a huge one, right? Being empathetic, putting yourself in their shoes, huge. And just acting professional and, you know, upholding those privacy guidelines for HIPAA. Social domains. So this is another quote from the book. Love and belonging are powerful needs. They determine our sense of well-being through others' acceptance and nurturing, affirms our humanity, and provides emotional fulfillment. So as surge techs, what do you guys think? How can we meet our patients' needs for love, belonging, and acceptance? And one that you already talked about, I think, is just touch. Not being afraid to touch the patient if you're not scrubbed in or whatever, and you're just kind of being the assistant to the circulator. But what else? You know, the book recommends offering support, listening, showing compassion, being reassuring, facilitating communication. Tell them we love them. Yes, you are here. We love you. We are going to take the best care of you that we possibly can, right? My preceptor would always say the same thing when the patient rolled in. She'd say her name and she would say, we're going to take really good care of you. She would always say that to every single patient. But yeah, just telling them, hey, you know, you have a really good team here. We can't make promises, right? We don't want to write checks that we can't cash, as far as you're going to be fine, or, you know, everything's going to be all right. Like, those are promises we really can't make, but we can promise we're going to do the best job that we possibly can. Yeah, include them in the conversation. On the little break that we had, I was talking with my mom. She's here with me for a couple of weeks, and she said, I told her what we were talking about. She said, nothing is worse than walking into an office, or you're gonna have surgery or whatever, and nobody talks to you. And they talk to each other, but they don't include you in that conversation, right? Like, that's a horrible feeling. Even if I'm standing at the Dillard's counter waiting to get some mascara and nobody, just looks around me and doesn't, acknowledge that I'm there. I don't like that, right? Reassure. Yep. Reassure them that we're a team. Yep. I agree with you guys. Any other thoughts? Awesome. I like talking about the patient, I'm not gonna lie. Self-esteem and image, body image. That's the way we perceive ourselves physically in the eyes of others, right? It's not always the same thing, right? How we perceive ourselves and or how we think others perceive us. Sometimes those things are a little bit different. Self-image is dependent not only on physical appearance, but also on people's normal role within their family and community, right? So what if you are the sole provider for your family and now you have to have surgery and you're not going to be able to work for a while or something of that sort? Like, our roles that we play within our family, that in our community, that's a big deal, right? We kind of associate ourselves with that. And a lot of times when people ask me who I am, I tell them I'm a teacher. But is that really who I am? I mean, it's what I do for a living, but I personify that, right? I use that as the image, right? That I'm going to tell somebody about who I am. So how's our patient going to be feeling if his or her body image or self-image is threatened? And how can we help in regards to self-esteem and self-image? What do you guys think? Yes, they do, Rainey. Chicks dig scars and really good stories that go along with them. Like, I got this scar from rescuing a baby from a burning building. For me, I think a couple things come to mind. One, keeping the patient as covered up as possible. If we don't need to expose them from, nipples to knees, then let's not do that, right? Like patient privacy. Have you guys, any of you that have ever been to get a massage, they just kind of discreetly uncover one part at a time, right? And so that you still feel protected and not just, like you're laying there in your nothings from head to toe. Like that feels weird. Remembering the golden rule. Yep, for sure. Yep, Yep, you're absolutely right, Ian. The teenager is going to care a lot more about self-image than the old codger is, right? He's going to have something to talk about around the coffee table with his buddies, right? But a teenager, not so much, right? That's different for them, for sure. Yep. When I was, there are a couple facilities that I've worked at, the way the room was situated, the operating room table, the foot of it faced the door that had a little window. And so anytime we had a procedure where the patient was going to be in lithotomy with their legs up, we had a little drape that we would put over the window. Just for a little bit more patient privacy. So the less traffic, when the patient is being put to sleep, it's really important that we're just quiet and there's not a whole bunch of background noise and stuff going on, so that we're just respectful, of that as well, I think is important. Yep. Reassurance is a big part of it too, I think. So some things I put down: patient may feel embarrassed, rejected, isolated, or they may be having their roles threatened. How we can help: we can listen, we can facilitate communication, show compassion, and reassure them. So self-actualization, how many of you guys think you're there? You are self-actualizing right now at this moment. You should all be raising your hands, right? Because you are here getting an education, right? And that's a part of self-actualization, of becoming, of rising to your full potential. And all of us in here are doing that. Age, yes. With age should come wisdom. Yep. You know, how many times have we heard, if I knew then what I know now, right? I'd like to go back to being 20 if I could take what I know now with me, right? We were just talking about not living in the moment and being like, oh, when I was 10, I couldn't wait to be 13. And when I was 13, I couldn't wait to be 16 so I could drive. And then I couldn't wait to, you know, be out on my own and then get married and have a family. And, you know, there's all of these things that we're thinking forward to, but we're missing maybe the moment. And so being in that moment, I think is you know, enjoying where we are in the journey is an important part. In regard to the patient, how the patient might be feeling, they could be feeling frustrated that they are having this downtime because they have to have surgery. They could be having feelings of grief and definitely vulnerability, like we talked about before. And for us, as far as how we can help, is just attempting to understand their feelings, their situation, and just having that empathy, right? Empathy is big. So coping with illness and stress. Another quote from the book: the patient's personal experiences through illness and surgery are unique to the individual. And depending upon previous experiences with illness, cultural factors, age, knowledge about their condition, and resilience to stress. Coping mechanisms, right? We all have those. Maybe some are healthier than others. Sometimes I cope by eating snacks or cake. I have this little video. It's a Franklin Covey video, and it is about paradigms. So we're gonna watch this video. Hopefully it will not make me log in, but if it does, figure it out. I probably have to stop sharing and reshare. So hold on one second while I cue this up.
See your friend, fantastic. You should have that around. I appreciate that.
So much of what we do in our personal lives and at the office is the result of the paradigms we hold. And what we do, in turn, affects the results we get.
Thanks for coming to the meeting today, everyone.
The word paradigm comes from the Greek root paradigma, meaning pattern. The pattern we expect to see, or the mental image of the way things are. We see everything through the perspective of our own paradigm. If you see your industry as one where growth is impossible, how does that affect what you do every day? And what results do you think you'll get from your actions? On the other hand, suppose you saw unlimited prospects for growth in your industry. How would that change your actions? What we see, our paradigms, determine what we do, which in turn determines what we get. And unless we consciously stand apart from and examine our paradigms, we might never see that perhaps many of them are distorted, short-sighted, or just flat out wrong. I remember a mini paradigm shift I experienced one Sunday morning on a subway in New York City. People were sitting very quietly, some reading, some resting with their eyes closed. Suddenly, a man and his children entered the subway car. The children ran yelling to the car, throwing things, grabbing people's newspapers. Their father sat down near me and closed his eyes and did nothing. I felt irritated. I could not believe he would let his children run wild like that. After a few minutes of patience and restraint, I turned to him and said, "Sir, your children are really disturbing a lot of people. I wonder if you could control them just a little more."
Yeah, you're right. I should do something. But we just came from the hospital where their mother died about an hour ago, and I guess they don't know how to handle it. Because I don't know how to handle it.
Can you imagine how I felt at that moment? My paradigm shifted. Suddenly I saw things differently. And because I saw differently, I thought differently. I felt differently. I acted differently. My irritation vanished. Compassion flowed freely. I wanted to help instead of criticizing and complaining. Once you see things as they really are, you'll think, feel, and act differently. And you'll do it automatically, spontaneously. Can you see why paradigms are deeper than attitudes and behavior? If you want to make minor changes in your life,
I know, Tori,
work on your
sorry.
behavior. But if you want to make significant quantum
I'm not
breakthrough,
gonna cry.
work on your paradigms.
What do you guys think? Hannah, are you laying on your pillow? You're so cute. Can you share one, Rainey? That was going to be my question. If you guys have had any experiences with paradigm shift.
Yeah, I was just starting to type. I think all of us are really arrogant in our own ignorance, if that makes sense. We're all very selfish creatures, humans are, right? And we tend to see things in a very narrow perspective and view and scope. And so when my dude and I started dating, you're still trying to figure things out with one another. And my ex-husband, my daughter, myself, my mom, all of us are like aggressive drivers. Not aggressive, just fast. We just, I don't know. It's like, we just got to get from point A to point B and we just got to go. Let's get there. He's a very cautious driver. And, we were driving to a different location and it was like, dude, why are we going so slow? And I just kept giving him a hard time over and over. And it was like different times in the relationship. And finally he looked at me and he goes, you have to understand the truck that I am in is a company truck. It's a driving, moving billboard. If I get pulled over, if anything happens, it's on me. It's a bad reflection on the company. There's all of these things. And it was like, for me, that was just this mind-blowing thought. I'm like, oh my gosh, I am seriously selfish and awful because that never crossed my mind. Never even dawned on me that there was an actual reason why he was driving this way. Because when he would get in my car, he'd drive like a bat out of hell, basically, And it was just like, okay. So now when we get in his truck and he drives the way he drives, I'm very content. I'm very happy with it and doesn't even cross my mind anymore. But it was one of those where I hate the fact that I can't just see the bigger picture. I have to have it explained to me like on
Ignore it.
such basic terms. So I don't know. I really feel like there are so many of those that kind of shape who you are. And if you're able to witness those and take them for what they are, it will actually shape you into a better human. I don't know. That's my deep thought for the moment.
I agree. Thank you so much for sharing. Yes, it's, you know, those reveals are pretty strong. Who else?
I have one. So I actually, this was one of my wife's, but it was like really good. She works as a CNA, and you're dealing with a lot of, you know, elderly people in homes. And they tend to be, you know, grouchy sometimes, and, you know, they just might not be having a good day. And as a CNA, sometimes you take that to heart because you're, you know, always going to take it to heart at first.
Sure.
But, you know, someone actually went up to her and told her, like, hey, you know, these people don't get to go home at the end of the day. This is their home. Like, they don't get to go anywhere. At the end of the day, you get to go home. And that for her was like huge shift in thought, like, oh, that's a good point. Now, you know, it's easier for her to be more compassionate and more understanding and helpful of these people, knowing that, you know, that's all they have. So it's like, that's really good.
That is really good. Thank you for sharing that. Absolutely. Great example. Yeah, I like to call like the way that we view the world, a lot of times is called our world view, right? But I like to call it our perspectacles, right? It's like our perspective glasses, lenses that we look at the world through. And to just, like Rainey said, kind of open our minds to like other possibilities, to seek understanding of others from others, because we're not sure what they're going through. And so that's, you know, it's hard because our experiences, our culture, the way that we were raised, all of those things shape us, right? For sure. Anybody else have one they want to share, a paradigm shift?
So I was at a store, and this, you know, mom was kind of like shouting at her kid, and it was like a big deal apparently, that her little kid couldn't have like a $2 candy bar or something. And I have like a whole ton of siblings, as you guys know. So I was all like, oh, you know, if you want, you know, what did I say? Because I try not to be intrusive, but like the little girl, she just seemed like she had a really tough day, you know how 2-year-olds can be. So I was like, hey, it's not a big deal. If you want, I can help out with that or whatever. And then she was like, well, when you have kids, you'll understand. I was like, well, I kind of rose 6 of them, because if you ask my younger siblings, they treat me like a third parent. They come ask me for things and whatever. And then she's like, aren't you a little young for that? I was like, I have 13 siblings. She goes, oh my goodness. And then after that, she was just like super lenient. She's like, how do you deal with that? Blah, blah, blah. And then she ended up buying the candy bar for the little girl. So I kind of felt happy, but like it was like a whole fuss. I was like, she's only 2. Why are you yelling at this poor little girl? So I think it opened her eyes a little bit.
Very nice. So that's really great for the flip, to bring in that flip side of things, Jonathan, and just point out that not only can others help us have a paradigm shift, but we can help others, right? In a gentle approach, maybe help them see another side of things. I had a situation, it's kind of similar to yours, Jonathan, where I helped someone to have a paradigm shift. And I had a student in my office, and she was upset about another student. And she was kind of saying, I don't like this, or I don't like that, or this she does makes me feel bad, whatever. And I said, do you know her story? And she said, no, I don't know anything about her. I just know that she's rude. And I said, well, here's my challenge for you. I'm going to challenge you to, in the next week, get to know her story. And then I want you to circle back with me. Tell me what you found out. And so in a week she did, and she said, so I did what you asked me to, and she and I have so much in common. We have, had some of the same trials and challenges, and I've learned why she kind of is the way that she is. And so I think that's always important. From a surge tech perspective, you will have individuals tell you working with Dr. So-and-so is awful, they're a real jerk, or whatever the case may be. But I challenge you to make your own story, develop your own perception of that person, instead of going off from what somebody else says. Yeah. Other questions or comments about paradigm shift?
I have
a really good video.
story. If that's okay.
Yeah, go ahead.
So I was serving in Scottsdale, like around December or whatnot, and everyone's in a good mood and all this good stuff, and I'm like having a good time being a server and a cocktail waitress. And in Old Town, there's a hospital like right down the street, and I didn't realize because I was new to the area. So I ended up, just like serving people, whatnot, and I had a couple and their son come in, and they already looked like they were kind of a little pretentious. And being in Scottsdale, like I get a lot of those clients or like those people. And so I'm like, okay, whatever. Like I'm just gonna have a good time with it and like, make my money or whatnot. And give them what they want. And so I was just like trying to, and in my head I was like, well, these are just like pretentious Scottsdale people. Like they're just like snotty Scottsdale people. And so I'm just ignoring their like weird mood, and I'm just trying to be playful and fun with them. And like once they close out, I made a comment that was like a little too playful for the mood, I guess. And she turns to me, and the wife turns to me, and she's like, I'm going through something right now. Like I just got back from the hospital and my dad is dying. Like, can you not? And I was just like, oh, like, I'm so sorry. Like, let me give you free dessert. She's like, I don't want dessert. Like, I don't care. Like, I'm ready to leave. Like, I need you to be more sensitive. And it really woke me up to the fact that like, sometimes somebody can look a certain way, but they're not, and they may act a certain way, but like we have no idea what they're dealing with. Like, and I really like my first perception because of what the environment that I was in was like, oh, like she was just like a snooty woman. Like, I'm just gonna try to be playful and like break down that barrier. Like, and in this situation, it wasn't even the fact that she had a barrier because she was snooty. It was because that she was going through something.
That is a very great point. Thank you for sharing that. It makes me think of, how they say like people wear masks or they like hide behind a mask. And sometimes that's how we cope with things, right? I remember always kind of feeling irritated, which is probably why we're not married anymore, with my ex-husband, because his coping mechanism was humor. And so the more stressful or grave a situation was, the more of the class clown he became. And, that, and it kind of makes me think, Rainey, like when we were getting to know each other, I didn't know his story. But come to find out, like he had a very like abusive alcoholic father and kind of felt like mom just stayed and didn't, protect him and his siblings and those kinds of things. So once you kind of start getting to know who that person is, you gain a better understanding of, of the masks that they wear, right? And maybe you're the one that can see behind the mask or behind the curtain, as it were. And I think a lot of us wear masks. You know, we're going through scary things, but we act like everything's okay, or we are irritable, or, you know, something like that. And it's kind of the mask that we hide behind. And our patients are going to do the same things, our friends, our family, you know, our peers. So it's good to have that awareness. Yeah, Tammy, that the humbling process, sometimes those are hard lessons, or we learn those lessons the hard way, for sure. So part of that, like, cultural competence that is kind of the buzzword that's out there, is just examining where our own biases come from. That's a big part of just identifying stereotypes, biases, prejudices. We all have them. We kind of put things in a box with a label. And the more we can kind of avoid that, the better. The better I think we'll be as humans, and the better patient care we can give. Do you guys want to take another 10-minute break? It's about 9:50. So I'm supposed to give you a break every 50 minutes. So let's come back at 10 o'clock. How does that sound? All right, I will see you in a few minutes. Okay. So what exactly is therapeutic communication? Tell me what that means. What do you guys think?
How you interact with the patients?
Definitely how we interact with the patients. And so what are some suggestions that the book gives about best practices? Alexis says active listening and being compassionate. Absolutely. Those are two very good examples. Yes.
Always clarify what you're doing.
Clarifying, right? Clarifying. Make sure that you clarify what the patient is needing, and then ask if the patient needs clarification, right? So that you both like get to on the same page kind of understanding. Yep, for sure. Ivana, eye contact, don't make jokes or use, hold on, use offensive language. Yes, for sure. Absolutely. And so Ian too, saying eye contact, not infantilizing, common language, not assuming understanding, right? Like that's all part of active listening, right? Where, have you guys ever been in a situation where you're having a conversation with someone and they're either looking down at their phone or they kind of start doing something else, and you just get the feeling that they're not completely focused on what you're saying? Have you guys ever had that, or is it just me?
Yes.
Yeah, that's not fun, right? You have it frequently, Ian? Yeah. So that does not feel good, right? Yeah. So when you, Ivana, when you practice it in communications, how did that make you feel?
It was actually with Miss Santacoy. She was like my partner, and I was trying to tell her something, and she kept looking everywhere, and I was like, why is she not paying attention? I was like, no, I'm gonna tell you because I like to share this story. But when we were talking about like our different experiences with our partners, some of my classmates said that they just stopped talking, like they felt uncomfortable. And I've had that with so many people, like where they just don't really respond and you feel like you're just wasting your time.
Exactly. That's very frustrating. Ian destroyed your favorite memory, Jacob. People are glued to their phones. They really are. I don't think I ever realized how frustrating that was, like what you guys are talking about, until I had the complete opposite experience with someone. And I was in Tucson. I was teaching there with a different school. And I had hired a full-time faculty member. His name is Gary. And Gary's desk was like right on the other side of the room, kind of just adjacent to me, but there was like a walkway between us. And so the very first time, like we really had an interaction, I stopped what I was doing. I was like, oh, hey. And I turned my chair this way to talk to him. And he was working at his computer. And so when I started talking, he stopped, he turned towards me, he put his hands in his lap, and he made eye contact, and he listened to me, what appeared him to be listening to me, the entire time that I was like sharing whatever I needed to share, which I don't remember now. But I do remember how that made me feel. And it brought to light how awful the flip side of the coin is, but how amazing that feels when somebody gives you enough respect to just focus on you, right? That feels so amazing. I know, me too. And when he did that, you know, it made me think, I want to make other people feel like that. Like, I want to do that for other people. So even sometimes when I was on campus and I would be working in my office and somebody would come in, right? And you guys know what this is like. You're in the middle of a thought, or you're like focused on a project, and somebody comes in, or your phone rings or whatever, and you're like, oh, you know, but I always make it a point to stop whatever I'm doing, wherever I am, and focus on that person, because I just remember how that made me feel. And, you know, making our patients feel like that, that's a big deal, right? Yes, thank you for sharing. Those are some great examples. The book defines therapeutic communication as a specific way of relating to a patient that encourages him or her to express any concerns and respond to those concerns with empathy and support, right? Allowing someone to express their concerns, that means they feel safe to express them, right? That means they feel like that you care, right? And that is always what we want to convey, not only to the patients, right, but the people that we work with on our surgical team, because at the end of the day, they're kind of our customers too, right? So some examples of ineffective questions or ineffective practices could be asking too many questions, sharing personal information. We kind of want to avoid sharing personal information about ourselves unless it becomes appropriate if you're having a sharing moment. But for the most part, we want to avoid that, joking or offensive language, like you guys said, making assumptions, giving misleading information, or appearing to be distracted. So we want to allow them to talk at their own pace, focus on them, remain professional at all times, get clarification, just like you guys said. Be honest about what you know, and I think more importantly, what you don't know. You know, it's okay to say, I don't know the answer to that, right? But then to follow up with, I will get someone who does, or I will find out. You know, that was my biggest fear, if I have to put a finger on a biggest fear when I started teaching, was if a student asked me a question, I didn't know the answer. And I remember talking to my department chair at the time, my program chair, and just voicing those concerns. And I said, what do I do? Like, what do I do if somebody asks me something I don't know? And she said, yeah, just tell them that you don't know and that you'll find out. And I'm like, okay, you know, and I can tell you that small little bit of advice really did take away a lot of anxiety and fear that I had, you know, because as a teacher, you want to know all the answers. As a parent, you want to know all the answers, right? As a caregiver, you want to know all the answers. As a friend, as whatever, like you want to be able to support the people that you care about. And, but one way we can support them is getting them the right information, even if we don't know it. That's just my opinion. So spirituality versus religion. What do you guys think? Are they the same? Are they different? Can you have one without the other? What do you guys think? They're different. Okay, religion is not equal to faith. Is that what you're saying, Ian? Or it's quasi-equal? Okay. Why? Why are they different? How are they different?
Faith is believing in something. Religion is a construct.
Okay. Yep. Religion is usually a secular thing with boundaries and set beliefs, right? Where spirituality is just, it's like this person on the bottom left, right? You can just be one with the universe. You can think there's a bigger power, whether it's whatever that power is. It's really up to you, right? Yep. Any other thoughts, comments?
Well, like kind of a funny story, I guess. My dad was brought up Mormon, and he was a cowboy his whole life, and he ended up becoming Jack Mormon. And like everybody in his community always tried to bring him back to the church because I don't know if there's any Mormons here, but I'm sorry, I get to say this because I was there. It's a cult. And his argument always was that he felt closer to God on top of a mountain on horseback than he could ever feel in the confines of a building with someone talking to him about how he should feel about God. And I just always thought, you know, to me that makes way more sense. But I think everybody also has their own opinions and, you know, where it is that they feel their religion or their spirituality or their faith. So I don't know. I just thought that was cool to have like some old cowboy, you know, kind of speak spirituality to me. It was always kind of a weird little oxymoron, I guess.
No, I like that. Yeah, it's whether you are getting in touch with your spirituality or with your religion, for me, I think that can be anywhere. It doesn't have to be in a building with some symbol on it, right? For us to be able to, that for me, I feel like we carry that with us wherever we go. And we can, I'm grateful that we can live in a country where we can worship how we want and when we want and what we want, as long as we're not hurting somebody else. You know, I totally agree with you. It's very individual, right? It's very personal, whether we're talking about spirituality or religion. It's as unique as each individual. In facilities, a lot of times they have like prayer rooms or and they'll have a chaplain. So it's kind of important that we just know where that is or if it is in our facility, so that if we encounter a situation in the cafeteria, we could guide someone there and say, well, we have a chaplain or we have these resources. I can remember, I don't know why I thought this. I guess I was just worried, but when my mom had her knee replaced, it was probably 3 hours before they came out to talk to us. And I don't know, whoever told us the surgeon was going to be out to talk to us. And so they took us to this little room off from the waiting area, my stepfather and I, and it was a prayer room. And there was like a Bible and there was like some different things. And so we're sitting there and we probably were waiting for like 20 minutes before the doctor came. And the longer I sat there, the more I convinced myself it was going to be bad news and they had put us in the prayer room for a reason. Like, maybe this isn't the best place where maybe I should have felt comforted, but the longer I sat there, the more worried I got. Like, is this going to be bad news? Like, is this why we're in the prayer room, or is this just where they usually take family? I don't know. But anyways, it's good to know that your facility has those things, and also that the patient may want to have some sort of artifact with them, or a rosary or something like that, and that we care for those things, that we don't lose them, or they might want to have a prayer at the bedside before you start, or whatever the case may be. So just having an awareness of that, and allowing them to do that, because I think ultimately that's going to result in a better outcome, the less anxious and the less afraid, less feared that they are. So the last part of the chapter really talks about all of these different specialty populations. And I think we've kind of dug through in A&P, we kind of dug down about when we were talking about growth and development and aging. Remember that fun lecture on aging? So we talked about the infant, the adolescent, the teenager, the young adult, the older adult, and we applied that to surgery. Do you guys remember that? Like special considerations for those populations. And so the book digs into that again a little bit. As far as the pediatric population, what do you guys remember about the pediatric population? What are some considerations?
Well, I think with them, we had to take into consideration their stage of development, like their emotional stage of development, not just their physical, because that would affect, obviously how they are interpreting the surgical environment and the type of care that they might need there.
For sure. For sure. Some facilities will let mom or dad like carry the infant back, or they have little red wagons for the older peds, or things like that. They give a teddy bear. Some like the infants, we talked about how blood loss, fluid loss, heat loss, all of those things, and insensible heat loss, right, are all really critical components with the pediatric patient as well. And I have a super funny story to share with you, and the takeaway I'd like you to tuck back in your brain for a later day when you're in a similar situation. But going back to my friend Gary that taught with me, he told a story about when he was in his externship. And they had this little patient, maybe 4 years old, that they had, I think they had done a tonsillectomy on this little girl. And he's in his training, in his clinicals, and so he's very new. And the little girl started waking up. She's kind of moving a little bit, and the anesthesia person said, just, kind of hold her arms down or whatever. And so he said, I didn't want to hurt her or anything. I was just kind of trying to keep control of her arms. Well, one got away, and she punched him right in the side of the head. And he got knocked out. Like, he fell to the ground. He's like, a 4-year-old knocked me out. So do not underestimate the strength of a little when they're waking up from anesthesia. That is the takeaway. Like, and we always laughed, like when he told that story. I think he told it to every group, but you know, the bigger they are, the harder they are to keep down, but don't underestimate the little ones either. You know, and go ahead. Sorry, Jonathan.
No, I got a funny story like that too. I have a little sister. She's a feisty one too. So I don't remember exactly what happened, but she fell, I think, from the trampoline or something, and she kind of got a bad opening in her head, and so she had to get stitches. And when she was there, you know, they gave her very minimum kind of painkillers, as they thought it was going to be a quick procedure. But this little girl, she was just so hyped up on adrenaline and pain and everything. There were 3 nurses. My mom was in the room with them. There were 3 nurses trying to hold her down, and she's like, no, and she's like, she's always breaking free and smacking them, and like the doctor just couldn't do it. So then they're like, all right. So like 2 nurses took her. She's like, do you want a blanket? She's like, yeah. And they wrapped her completely in a blanket so she couldn't pick up her arms and move. And then whenever they started stitching again, you just see her face turn purple. My mom recording the whole thing because to her it's the funniest thing, but like at the same time she's like really sad. She's like, oh, my poor baby. Like you can hear her in the video, but like at the same time she's laughing because there's so many people around just this little girl. She's wrapped up in a blanket, yet she's still getting through to like squirm and make it so difficult.
Oh yes, thank you for confirming my crazy story. Yeah, you know, I mean, and they're wiggly, like they can get free more easily. They're sprightly, you know, and determined, for sure. Yeah, thank you for sharing that. Yeah. Yep, Alyssa. You know, and a lot of times they, you know, won't start an IV or anything like that on the little ones. They'll bring them back to the OR and give them some like gas through their oxygen mask or whatever to make them sleepy before they ever poke them with anything or whatever too. Yep, watch out for the littles. That's good advice. The older patients, some concerns definitely with range of motion when we're positioning them, you know, and the friability of their skin, right? Because their skin integrity isn't going to be as good as the younger peeps. So when we're moving them or positioning them or anything, definitely important to take that into consideration. And then, you know, something else we want to think about with the older folks is if they're going to need post-op care, and is there somebody there that's going to be able to help take care of them? Are they going to be able to perform their activities of daily living, their ADLs, like by themselves? If not, and they don't have anyone, they might need to go to like an acute, you know, short time, like care facility or something like that. Let's see, they could be cognitively impaired. They could have nutritional deficiencies as well because they kind of lose their sense of taste and sense of smell. So they don't really want to, you know, they might lose that, like that desire to eat. And so a lot of times that can contribute. And then, you know, whatever illnesses that they may have. You know, they could have a variety of illnesses, chronic illnesses with their kidneys or their heart or their whatever. So those things start to decline over time, like we talked about. And then that makes me think of one thing Ian said about not treating them like children, you know, just making sure that we use plain language and we, you know, give them respect and talk to them like they're adults and not children. Make sure our tone is the correct tone. Sensory deficit. This is an issue because we typically want to take anything that the patient has and box it up right before they go to surgery. So if they have hearing aids, if they have glasses, whatever the case may be, we're going to let them keep them for as long as possible. But at some point, we're probably going to ask them to turn them over to us so that they don't get lost or broken or you know, if they have metal, then that could be another situation when we use cauteries. So, you know, if they're hearing impaired or sight impaired, you know, that's going to impact communication and those kinds of things. If they're sight impaired and their hearing is fine, then we want to amp up the communication, right? Make sure we tell them everything before we do it so that there aren't any surprises. The malnourished patient, again, malnourishment is going to impair healing, and it could impair a bunch of other their body systems as well. So they may not heal as well, may not do as well during surgery, that kind of thing. The bariatric patient, statistically, the book says that more than 60% of adults in our country are overweight or obese. How does that impact us as surg techs?
It forces us to be more prepared in the OR, as there could be, you know, so many complications during surgery or anything. So we just have to be aware of the patient's status at all times and making sure that we have the accessible, I guess, instruments and such to take care of anything that could occur.
For sure. You're absolutely right. Any other thoughts?
Patient positioning. Just because of the extra weight, certain positions can cause a lack of blood flow to certain areas or difficulty breathing, and just things like that.
For sure. For sure. If we have that patient laying flat, then all of that weight is pressing down on their lungs too, right? Which is could lead to respiratory distress. Yep, you got it. You got it. Any other thoughts? I think from our perspective, in addition to, you know, Jonathan brought up making sure we have the correct instrumentation. That's a big one. Positioning is a big one. Like Tori said, being prepared for other procedures, right? We may be going in the belly for something and we may find something else. Like a lot of times we'll find an angry gallbladder or something. And so we need to kind of think ahead and be prepared for those things. Another thing with these individuals is it's going to take, because of their mass, it's going to take a lot more anesthetic to get the patient asleep, but then it's going to take them longer to metabolize that, right? So it's like, you know, giving them a horse tranquilizer that takes forever for it to work. And then when it finally does work, it's going to last for longer than we probably want it to, because the metabolism of it is going to be a lot slower. So you may be in a situation where the patient's just sitting in the OR and you're done with the case and you've already taken you're not supposed to leave the room when your patient is still in there, but sometimes they will, you know, someone will come and say, just take your stuff. And, you know, you might take your stuff and come back and the patient's still in there. Like they can't take the tube out yet because the patient's not awake or able to breathe on their own. So those are some situations we can encounter as well. And then moving them and handling them, typically minimum of 4 people to handle a patient that can't move themselves. But when we have a bariatric patient, then we're going to need more people to help us move and position so that we're safe and so that the patient is safe, right? That's another big concern for us. Diabetic patients, we've talked about that as we went through our micro and our A&P, just about how, you know, because of their vascular disease associated with diabetes. It could impair their healing. They could be coming to us because they need an amputation or those kinds of things. And so healing is really going to be compromised with those individuals. The trauma patient, that's always a fun one. The trauma patient, what do you guys think from our, oh, I just saw your comment, Alyssa, about 600-pound life. But then circling back to Rainey, is there a special OR table? Yes, there is. There are special bariatric tables. And like positioning devices, like some OR suites are specifically set up for bariatric patients where they have like the hoist or the lift that can help us move the patient. Some of these really large patients will have what's called a paniculectomy. And it's like that part of the abdomen that like kind of hangs down really low, like a curtain. They call it a pannus. And so sometimes it will be a paniculectomy, and they have this special thing like hangs from the ceilings, and you put hooks in the patient's pannus and you literally like hoist it up so that the whole pannus is like hanging, so that they can, you know, cut that off and resect it. I remember one specific experience that I had was like exploratory laparotomy. It was a very large individual. And the surgeon said, you have to be really careful with these individuals, because he asked us to like pull up the pannus and like hold it up so he could make his abdominal incision, because he said sometimes you'll just cut through that pannus and like you never find the abdomen, you know, they're inside the abdomen. So having an awareness of those kinds of things too is something that I would never even think about. So yeah, there's definitely specialty beds, positioning equipment, and other equipment as well. I think I skipped immunocompromised, but I think we've kind of beat that horse to death. So I don't know that we need to talk about immunocompromised patients anymore. Trauma patients, most commonly for older adults, is falls, 40% of them. So if you have a large population of older people, and Arizona does anyways, you know, broken hips, broken wrists, those are kind of common things that we see as far as older adult traumas. Motor vehicle accidents is another one. And the most common injury for MVA is splenectomy, ruptured spleen from the steering wheel. So, and then sometimes they might have multiple injuries. So you may have more than one surge tech and more than one nurse and more than one surgeon in there working on this person. You know, if they have a brain bleed and they have femoral artery laceration, I don't know, whatever the case may be, but you may have multiple teams in there at the same time, and that can be kind of crazy. Questions, comments about any of these up to trauma? Developmental disabilities. With developmental disabilities, we want to make sure that we're not thinking of, and this is across the board, not to think of patients as the procedure that they're having or the condition that they have. And a lot of times we'll do this, right? We'll be like, oh, what are you doing today? Oh, I have a hysterectomy in room 5, right? Like, we don't know the patient's name. We just know that it's a hysterectomy. We know them by the procedure we do on them. And sometimes that has a tendency to depersonify the patient. And then once there's only this much of them showing, right? Like once you get under the hood, so to speak, like you just kind of see them as a bunch of tubes and wires, you know, and you get focused in. And I think it's always important to zoom out and just remember that this is actually like a human being, especially after you've done 3,000 surgeries. Like after a while, it just becomes like, you know, this is what I do. I'm a human mechanic, right? So it's an important across the board, I think, that we just don't see them as their disease or their procedure, that we actually see them as a person. I had a situation with a patient that had a developmental disability, and she also had like severe contracture. So when they brought her in on the gurney, we actually did a pap smear in the OR for her because they weren't able to do it in the office. I think they had attempted to do it and it was a poor outcome. So they brought her into the OR, and in the gurney, like her knees were kind of pulled up to her chest and her arms were up to her chest as well, kind of up to her neck. And but when we put her to sleep, an amazing thing happened. Like her whole body completely stretched out and relaxed. But taking into consideration that her limbs never like moved that way, we made sure that we kept her arms just, you know, bent at more of an angle and those kinds of things, so that when she woke up, she hopefully wouldn't have as much discomfort because her body isn't used to moving in that wide range of motion. So those are some things to take into consideration as well. Skeletal malformations.
So the thing about the, you know, patient first rather than their disability or whatever. So my little brother has Mowat-Wilson syndrome. He had his baby, so like it's very rare, but he's seen a whole ton of doctors and my mom's loved them all, but one. And it was like the third time she saw this guy, and he comes in, he goes, "How's my special little guy today?" My mom got really offended by that because you're just like, "Oh, hey, Ruben," you know, and they'll come in like kind of laughing, like, "How are you doing today?" and all that. But, you know, he came in just the third time, was like, "How's my special little guy?" So like emphasizing kind of the special thing, at least in my mom's head. And she was like, "I'm sorry, can we get another doctor for today?" Like that was immediate reaction of it, and like he was kind of offended. I was with her, so like I kind of saw the whole thing play out. I didn't understand it at the time. I was like 17, so I was just stuck in my head, I guess. But it just makes more sense now, like that she did that.
Sure. Thank you for sharing that. I can totally see that. It made me think of, have you guys seen the movie Forrest Gump? And she takes him to school, right? He's young. And so she takes Forrest to school, and he has like the aptitude test, and he scores pretty low. And so on the way home, she's telling him like, "You're special. You're special, you know, and all this thing about him being special." And then by the time they get home, she's saying, "Forrest, you are no different than anyone else. You are the same as everyone else." So, you know, we are all unique in our own way, but there are similarities that connect us all, no matter what. And keeping both of those things in our mind simultaneously, I think, is extremely important. That's one of my favorite movies. But yes, indeed, I can totally understand that. Psychosocial trauma, we're talking about individuals with post-traumatic stress syndrome specifically, and that there can be certain triggers for them, whether it's a loud noise or a bright flash of light or something that, you know, they're having a specific procedure and that is on a specific body part, and that is a trigger for them. So just to keep that in mind, who was talking about, Sean, when you were saying about it's hard not to take things personally. When I had the situation where my charge nurse said, you know, "There's a case tomorrow and the patient has requested you not to be in there." Like immediately I took it to heart. And then when I found out why, like, that was okay. But I was defensive immediately because of that. And like, why wouldn't somebody want me in there? Like, what have I done? What's not good? Why am I not good enough? Or I had a similar situation where a surgeon came in and he saw me in his room and he went and told my charge nurse that he didn't want me in there. He wanted the tech that usually worked with him. And I didn't understand that at the time. And I was extremely hurt by that. He was a very nice guy. And later, the next day, I guess, came to find me at work to share his reasoning with me. That was a huge paradigm shift for me, because here I am feeling the whole time like he doesn't think I'm competent to scrub his case. And so when he came to talk to me, he said, it's not personal, but Liz does all of these cases with me, and it was a total knee replacement, and it was a different system that I had never used before. I worked with another orthopod who used a different system and had a different routine, but Liz was with him routinely for these cases. And he said, Liz knows my routine, and because of that, it's less surgical time for the patient. And I never even thought of that. Like how, even though I'm competent, not being familiar with this particular system could either add or subtract from the patient outcome. And I had never thought of that. But I appreciated him explaining that to me, and it totally makes sense. Let me see Jacob's question. Do you still get paid even if you get removed from the case? If you're there, you're going to get paid. I mean, there was another room that I was put in, so yes, definitely. And if you're not in a room, usually there's other things that you can be doing. Yeah, whether it's like getting cases ready for the next day, or helping out in sterile processing, or restocking, busy work stuff. But yeah.
I feel like some of those experiences that we have where we take things personally at first are good, because it helps to kind of callous us to some of the treatment that we get in the long run. And that's like really important.
It is. The OR is not a warm and fuzzy environment. And for any of you that work in the healthcare field, it's not warm and fuzzy most of the time. But the OR can be on a different level of lack of warmth and fuzziness. So not taking things personally is going to be super important, because there are going to be times when you have a really hard case and the surgeon doesn't say thank you, or he's just kind of grumbly the whole time, or whatever the case may be, or there's a poor outcome. I mean, there's so many things that can happen, but it's not warm and fuzzy, for sure. And, kind of developing a thicker skin is an important part. It really is. You're absolutely right. Let's see, where are we? We're talking about PTSD. Okay, so the pregnant patient, the number one thing that is on my mind with the pregnant patient, and we're operating on them, what do you guys think? The number one concern for the surge tech. What about the baby, Rainey? Making sure the baby's safe. Yes. As surge techs, how can we do that? Any thoughts? I mean, making sure mom is safe is good too. Could definitely have the fetal monitor on. That's something that's not sterile, so that's probably not something that we would do. But what is something that we would be directly involved in? Positioning. What?
Positioning.
Not positioning, especially if we're scrubbed in. We're not going to be involved in positioning. But positioning is important, because we don't want mom laying flat on her back, right? We want mom, we usually put a bump under the right hip so that it shifts baby off from the vena cava. So that is definitely an important consideration. But there's one specific thing I'm thinking of for the surge tech that we should be prepared for in case something should happen.
Delivery?
Yes. C-section, right? Yes. So we should keep our eyes and ears open just in case there is a situation where we have to do an emergency C-section. That should always be tucked in the back of your mind. If you're operating on a mama, then have C-section stuff in the room. Okay, that's an important part of us getting ready for our job and being able to anticipate the needs of the patient and the needs of the team. I would probably just have it available. Like I would have the tray and the supplies and everything just kind of in the corner or right outside the door in the case cart or something, but definitely have it nearby unless you're otherwise instructed. Let's say mama is close to term. Then your surgeon might say, we need to be prepared to do a C-section. Like there's different, scenarios for each patient. So if you know that, mama is close to term, then it's a good question to ask. Hey, just in case, do you want me to have the C-section stuff open and ready to go? Like you can open the tray and count it. And, that's not too much of a setback for the facility. The soft supplies, the disposable supplies are probably more of a cost. So, maybe keep the sutures to the side or, whatever the case may be. But no, I have not, Hannah. I have not. I have done emergency C-sections, but not one while operating on a pregnant lady. Thank goodness. That's stressful. Yeah, I can't speak to that experience, but I can speak to emergency C-section, and that's crazy enough. Yeah, good question. Yeah, so those are the things I would think about most about pregnant patient. And then lastly, the isolation patient. We have substance abuse. Substance abuse gets a little bit of a shout out. The one thing I think about with substance abuse is that it's going to take more medication to put them to sleep and keep them asleep. And so that can be a situation for us because the patient could start to move around during surgery. One thing you want to avoid saying, which I think is a trigger for all anesthesia care providers because I think they take it personally, is when you say the patient is waking up. So if the patient starts to move intraoperatively, that's not the best phrase. You can say the patient is moving, the patient moved their arm. You can speak specifically to what the movement is, but I think they take it very personally when you say the patient is waking up because their job is to keep the patient asleep. And so I think that can come off as a personal a slight to them. So definitely good to let anesthesia know the patient is moving. Probably not by saying they're waking up though. And then lastly, the isolation patient. We've been talking about this just because of the whole COVID pandemic and all of that, wearing the right PPE. The other thing that I thought of when I was reading this is making sure the patient wears a mask if you're transporting them through the hospital, right? And they're on droplet precautions. Let's say they have TB or the COVID virus or something like that that is transmitted through the air. You want to make sure you put a mask on your patient, okay, if you're going to be taking them through the general public areas of the hospital. Let's say for some reason you go to help transport a patient from the floor up to the OR. Okay. That's all I got. What do you guys got? Anything unclear? Any comments? Any questions left unanswered about the material? Anything?
I have a question, Ms. Windsor.
Yes.
So in the reading, kind of towards the beginning of the chapter, it talked about, how a patient's going to have their family member there, they're going to have a significant other or just their support person or whoever it may be. And we're kind of making sure that they have a plan for discharge and recovery and things like that. What if their person that's there, and it could be a child, it can be, any age range up to geriatric, is not a safe person for them to be
with? So that's a fantastic question. At that point, I think is when we would just need to get like, okay, so at bigger facilities, they have like social workers that you can, if you sense that or somebody is sensing that, or let's say, and I've never had this happen before, but let's say we get the patient into the operating room and we take off their gown and there are numerous bruises or something that makes us a light go off on our head, then, that's when we need to get adult protective services involved. And I can remember my mom was having a procedure done. Maybe she was having her pacemaker, and they had a social worker come and interview her before her surgery. And the first question she asked is, do you feel safe at home? Like she interviewed my mom, and I'm like, and she asked me to leave, so she could just speak to my mom by herself, nobody else around. And, so they had their conversation. I came back and I'm like, what was that all about? And she's like, oh, she was just asking me, like, do I feel safe at home? Do I feel threatened at all? Like, is there somebody there to take care of me? Do I have stairs? Like all of these things. But, so I think, a lot of the facilities are thinking along the same lines as you, of just making sure, doing their due diligence beforehand, just having that conversation with the patient. And then if we notice anything wonky, like taking the responsibility to say, hey, like, this doesn't seem right, this doesn't look right. Maybe you're going to lunch and you see an altercation. I mean, I don't know, whatever the case may be, but just to communicate that through the right channels. Yeah, that's a fantastic question, with not an easy answer, but those are some of my thoughts. You're picking my brain. What other questions or comments do you guys have? Anything? Are you guys bored?
I have another question.
Okay.
When it talks about certain religions and not believing in the blood transfusion or any type of blood products, even their own or anything like that, it made reference to Jehovah's Witnesses and how the adults can make that decision, but it didn't state what happens when it's a child. And if that parent has that say and that that's a consideration, but something happens in the OR, or where is that line?
The surgeon is going to make that call, probably surgeon and anesthesia care provider. The rumor is that two doctors can make a decision for a patient. And there are no really good lines. I can tell you that I had one situation with an adult patient that had signed the form that said they did not want blood, but blood would save their life. And they got a court order or something so that we could give the patient blood. And then I do know of one other situation, which was one of my students a long time ago. He was an EMT, And he said there was a situation with like a 16 or 17-year-old girl. Her parents were Jehovah's Witness, and she needed a blood transfusion, and they said no. And she said, yes, I want it. So they ended up giving her the transfusion, and the parents sued the county, state, whatever, because of that. And I don't know what the outcome was, but my guess is probably the courts would say that she was of sound mind and she could speak for herself. I don't know what the case was, but it is a very rare occasion that we were going to let somebody die in the operating room, if there's something that we can do. But that's not going to be our call. It's going to be the surgeon's call. Like I said, anesthesia care providers call. They're going to decide that together. Or if they can, I could see physician or surgeon going out to talk to the family and saying, hey, like, it's what does my dad call it? It's like an 8 a.m. idea, and now it's 5 p.m. and it doesn't sound like that good of an idea. Before surgery, when everything is fine and your child is stable, you're like, yeah, no, this is our culture. We don't do this. But in the situation where it's either give your child blood or they die, that could be a different decision that you're making. I don't know. So having that conversation with the family at that time is going to be an important piece too. Yeah, thank goodness we don't have to make those decisions. Yeah, you're welcome. We just have to support the team, and the patients' decisions, families' decisions, care. I don't know. It can get sticky in some of those situations, for sure. Yeah. Nothing's worse than having a patient die on the table. I'll tell you that. Other questions or comments? All right. Do you guys need another 10-minute break? It's been 50 minutes. I'm supposed to give you a 10-minute break. Okay, take 10 minutes. I think that will take us to like 5 after 11. We'll look at some instruments, and then that will probably wrap it up for us for today. Okay? All right, I will see you in 10 minutes. Zoom recording, okay. All right, so these are the basic instruments that we have been looking at, and any of these on the list are fair game for our test, in addition to what they do, what they're used for, what the category is, any and all of that stuff. Like I said, I'm gonna record at least the chapter 1 and chapter 2 for our instrument book and have those as resources for you. So any of the fun stuff in there could also be fair game. So having said that, what is this that we're looking at? Shout it out or type it out.
Cryo?
Yeah. Oops. I didn't want to do that. I wanted to click this. That's a cryo, right? And our category is clamping and occluding. How do we know that it's a cryo? Remember, we can look here and see that these ridges go all the way from the tip of the jaw all the way to the box lock. Belly is typically about halfway, right? So clamping in clamping a vessel, whatever the case may be. Okay. Good job. Thank you, Rulan. What about this?
Is it a number 11?
Yes, ma'am. It's a number 11. And what handle do we put that guy on? A number 7. Yep, 7-11. It can go on the number 3 as well. But 7 is typically what we loaded on. What about this guy?
$10.
Mm-hmm. That's a number 10 blade. Good job. Fits on the number 3 handle. What about this? Starts with a B. Yep. You got it, Rainey. That is the Babcock. That's the Babcock. Good for grasping internal tissues like the bowel, the stomach. It's atraumatic. Tubular structures like the fallopian tubes or something like that. It is a grasping and holding. This one's kind of difficult to tell. Can we see in there? I don't know. Is it a Kelly? Yeah, it's kind of hard to see the tip of it. But remember, the ridges on the Kelly, they only go about halfway down the jaw. Make this a little bit bigger so we can see it. Anybody remember this guy? Oh, Rulon got it, the Ferris. That's a good guess, Ian. We do have that one coming up. Good guess. And the Russian is the forceps, for sure. This one is the Ferris. I call it the fat Ferris because in a relationship to the Bonnie forceps, which looks a lot like it, this part here is a lot wider where you put your thumb than the Bonnie. Very aggressive at the tip. You can see it has this big tooth. Good for orthopedics like this to close like the joint capsule, those kinds of things. Good yobs. What about this? It has a weird little nose on it, but I think we can get close. Anybody want to take a shot at what it is? It is a type of needle holder, but it's not a Mayo Hagar. It's a rider. Yep. Anna has got it. The rider has this little notch, this little cut in right here on each side. But it is a needle holder, and its category is suturing and stapling. The book calls it. I would just say suturing, but it says and stapling. So I guess they kind of lump those together. Nice jobs. What about this one? Mm-hmm. Thank you, Sean. That's a mixture. And these can come in different lengths. They're very close to a right angle, but this is a little bit less of a curve on the tip. The right angle has a 90-degree, where this has like more of a curve, not quite 90. Clamping and occluding. Clamping and occluding. What about this? We haven't seen this one before together. Anybody? Yep. This is the Lister bandage scissor. And you're gonna see these in orthopedic trays because we use them to cut the drapes off, because they'll usually have like this stockinette. It's like a sock-like thing that goes over the hand or the foot. So this works really well for cutting that. The drape that we put on the patient is extremity drape, kind of just has like this stretchy hole in the middle, and you can't really tear it off or just pull it off. So we cut it off. So the bandage scissors are super good for that. They're also the scissor that we're going to use in a C-section. So see this really blunted tip right here? When we're doing a C-section, we're going to pass the surgeon the knife to cut into the uterus. And the surgeon's just going to make a small little incision in the uterus. And then we're going to pass the bandage scissor, and that blunted part of the bandage scissor is going to go into the uterus, and that other one's going to be on the top, and they're going to cut that, extend that incision into the uterus. And then they'll use this to cut the cord, and this typically goes off with the baby. You might see one with plastic handles as well, but not for C-sections, but in the orthopedic trays. Okay, cutting is the category. Lister bandage scissor. Here's a forceps with teephases. I don't think this one has a special name. Toothed tissue forceps. Toothed tissue forceps for grasping and holding. What about this? Any guesses? Some sort of scissor. A wire cutter. Yep, you got it. Again, could see these in orthopedic cases where we're using wires to put a bone back together. Another situation where we use these is if a patient is having a breast biopsy and they've had something done called a needle localization, then they've been in radiology before they've come to us, and the radiologist has inserted a wire into the mass that we are removing. And the patient comes in with this antenna sticking out of their breast, and usually they cover it with like a styrofoam cup and like tape it to the patient. But before the nurse does the prep, they're gonna cut the wire a little bit shorter, just like yay. And so typically for those, we want this scissor in there because it's good to use for that. And then they'll prep the little part of the wire that's still sticking out. Wire cutter. We got a needle holder here, another type of needle holder. This one's called a Cryl wood. And the Cryl wood, and it's kind of hard to tell from these pictures, but is more dainty than the Mayo Hagar. The tip of this is more dainty. It's going to be for a smaller, more delicate type suture needle, but they still have the length, okay? Ooh, what about this? What is this? Who knows?
Suction?
Yeah, good job. That is a suction tip. It's called a Yankauer. A Yankauer suction tip. And this is the disposable version. Can you tell that it's like this blue plasticky stuff? And that actually gets thrown away. It's a single-use item. And they come in like our disposable basins or in single packages that we can open, but there are also metal ones that aren't disposable as well. And an important thing to remember about the metal one is that this tip right here on a metal one comes off. It's a separate part. So it gets counted as Yankauer with tip. Now this plastic one doesn't because it's all one piece, but the metal Yankauer does have this tip like screws on and off. And so when you count it, it would be Yankauer with tip, all right? A lot of times we don't count the plastic ones, but some places might, I guess. And so the only place that suctions is right here it's focused at this little tip right here, okay? Good job. Who remembers this? It is sin-like, Rainy. You're close. Remember, the sin has that little right angle on the other end. Yeah. The Volkmann. We usually call them rakes, like you would rake your yard with. We usually call them rakes, but specifically the Volkmann. I've never heard a surgeon say, please pass the Volkmann. They usually say, give me the rake. Right? And there's some different flavors of rakes out there, but so this is one type. It's a handheld retractor. Good job. Okay, Ian, you're on. What's this? Yeah, still Russian. That's what you are when you're going into the bathroom, right? Russian. All right. Yeah, so this is the Russian. It's kind of similar to the DeBakey in where it's nice for grasping and holding tissue, but it's not traumatic. Okay, so it's atraumatic. It comes in different lengths. The OBGYNs really like this one. Can you guys tell what number this blade is? Has this big cutout?
20.
Yep, it's a 20, and it fits on what? A 4. Yep, you got it. Good job. All right, a couple more because I do need to meet with my team leaders. What's this? Ooh, we looked at this in the lab yesterday.
Goulet?
Yes.
Goulet?
Goulet. Kind of like ole, but goulet. Very good. Handheld retractor, right? Retracting and viewing is our category. I think this is the Carmalt. I always get that. Yeah, the Carmalt has like a weird, can we see the jaws? They're almost like no ridges at all inside here on the Carmalt. Again, they're used for clamping and occluding. They're heavier than the Cryo or the Kelly. They're a little bit longer, a little bit heavier. So they can take a bigger bite of tissue and they can bite heavier types of tissue or clamp and occlude heavier tissues. All right, so that one's the Carmalt. Okay, questions about any of these so far? I think we're gonna stop here for now. Any questions or comments that you guys have? We'll look at more on Friday. Get you ready for your test.